panelists. Our first speaker, Joan, is well known to many people. She's a nurse and part of the executive of Palchase and responsible for advocacy in Palchase, and has been involved in HIV/AIDS support for more than 36 years. We also have a recording from Father Rick Bauer, who again is well known to many of us. He's a board certified chaplain in the US, working at George Washington University, and also has experience in HIV/AIDS, particularly in Africa, for more than 40 years. Ethan joins us as a panelist. Ethan is joining us from Kentucky in the middle of the night this morning, but he also has done an internship in Africa, and particularly looking at the adolescents. And that's a fantastic addition to our panel this morning. I'll also be contributing and coordinating the panel. My name is Moira Leng. I'm a palliative care physician working in different international settings, particularly in Gaza and also in India and in Uganda. So over to you, Joan. Thank you.
Thank you so much, Moira. And a big thank you to Ethan, who's going to move my slides forward, as I have a bit of a challenge with my share screen facility. So Ethan, if I could ask you to put up my slides. Thank you. That's great. I can see them. So I'm going to talk a little bit today about an overview of living with HIV and AIDS in humanitarian settings, and why it's important that palliative care is integrated into the care and support of people with HIV and AIDS in these particular settings. But of course, what we're going to talk about, as Moira said, is relevant to a number of settings. And I think there's a growing concern that people who live in extreme poverty over a long period of time could also be considered as a humanitarian setting. So Ethan, if you could go to the next slide, please. I just want to say that often when you talk about palliative care for people with HIV, the first thing people say is, oh, but we have antiretroviral therapy. But we know that not everyone is compliant on that therapy, and that there could be complications and various social impacts that prevent people accessing or being maintained on their antiretroviral therapy. We also know that palliative care can improve the quality of life, relieve the suffering, and promote compliance in people living with HIV and AIDS. And there is really good research about this that is available. So those are two concepts I would like us to keep in mind, that antiretroviral therapy is wonderful, but sometimes it is not enough. Next slide, please, Ethan. So we're just going to look at a picture of the world. There are 39 million people living with HIV across the world. We know that the majority are living in Africa, with a large number in Asia as well. But wherever you go in the world, you probably will find people living with HIV. And they are part, some of them are part of the almost 310 million who need humanitarian aid. And a complicating factor is that most of them are living in low and middle income countries. Many of them are living in poverty, and many are affected by conflict, by climate change, and by the need to migrate because of economic factors. And the latest statistics can be found in the Global Humanitarian Overview, the mid-year update for 2024, and that is available on the OCHA website. Next slide, please. And so I want you for a moment to imagine that you're someone with HIV, you live in Sudan, you have been getting your antiretrovirals and, and having tests done at a clinic that you know and where you are known as well. And then when the conflict broke out, you need to move for your own safety and your family's safety. You might move to somewhere else in the same country, but after a while you realize you have to move out. But you actually are moving into countries which have enormous numbers of problems. My apologies. Where there is also great poverty. Many people living with malnutrition, people living in conflict, countries that are living with climate change impact. And so while you're moving out of a conflict zone, you're not moving into an easy zone. You don't know the people, you don't know the health system, and the health system may be struggling with the existing numbers of people with HIV and are struggling to handle the extras who are migrants and who are refugees. Next slide, please. Sorry. These are just looking at this from two angles, one from the humanitarian crisis side and the other the need of palliative care in HIV, from some research done by Richard Harding. But in a humanitarian crisis, there's usually a breakdown of your social networks, health institutions, your support networks, and a mass displacement of people. And you either become vulnerable to HIV for reasons we'll discuss, or your HIV status is actually impacted by this. And so we know that palliative care can support people living with HIV and AIDS of all ages, from that baby through to the older person, but it's usually lacking in humanitarian settings. And if you're not taking your antiretrovirals, you have a more chance of getting pain and symptoms, side effects, virological failure, and that leads to infections and comorbidities. And so if we look at these two together, we can see why we need palliative care in humanitarian settings for people with HIV. Next slide, please, Ethan. Thank you. And so while there are factors that affect all people who are migrants, refugees from any type of humanitarian reason, there are others that particularly impact people with HIV. The one is that once you move away from the known, from where you are settled, a group that is particularly vulnerable are children. Often they do not know their status. They do not know they've got HIV. It hasn't been revealed to them. They're dependent on adults to provide the medication, to get them to their clinics. And often in this situation, getting a child to clinic for HIV is not seen as important to the family. They're trying to survive. The child might be separated from the family, and those who look after them do not know their status. And we know with HIV, if you stop taking your antiretrovirals, in the beginning, you'll be okay, but the symptoms will start more slowly later on. Then, of course, there's the stigma. There's the stigma of having HIV, which is still huge across the world. Unfortunately, it shouldn't be, but also the stigma of being a migrant, of being a refugee, of being a strange person in a particular area. In humanitarian crisis, there are increasing barriers to accessing healthcare and medication, simply because of the breakdown of routes of obtaining your medications, because of climate change, floods, earthquakes. You do not have access to the health centers, and health centers that are destroyed as well. We also know that there's an increase in sexual violence, and of course that is going to lead to an increase in HIV spread. And a particularly vulnerable group are babies who are newborn, because in a humanitarian crisis, there's sometimes a more than 50% increase in the number of premature and complex births. And if you don't have access to antiretrovirals, that baby could be born with HIV or could get it later on. And then, of course, the issue of traumatic injuries and disabilities, which not only prevent you accessing your HIV, but HIV medications, but also could be a danger to those caring for you if your blood is contaminated and impacts on them as well. So next slide, please. And the special concerns we've mentioned already is the separation from families, dependence on adults for their medication and their treatment and care, not knowing their diagnosis, and being very vulnerable to abuse and neglect as well. Next slide, please. And so what are the barriers? The HIV services may be affected. They may not. They might still remain there. And in some countries, they've got it right to build up those services again, and we'll talk about that later. They could be destroyed, either the roads to them destroyed or the actual service itself destroyed. And as I've mentioned, it might be that as people migrate to other areas, to safer areas, those services are unable to cope. Inadequate resources and medications, either because they can't reach you or because we have too many people with HIV trying to access them. When you stop antiretrovirals, it can take a while before you show the symptoms. And so it means there's a late diagnosis and treatment. And HIV, because it doesn't immediately impact on the health of the person when they don't take their medication, is not seen as a priority condition. I mentioned the fear of disclosure in a new place. They're not going to want me because I'm a migrant or a refugee. And if I say I'm HIV, that might be even worse. And so people are afraid of actually speaking about their status. And so conflict and climate change can also block access. And as we see from this drawing by a Rohingya refugee child, simply going into an area like that is not an option. Next slide, please, Ethan. We've mentioned this before. There is, in certain humanitarian settings, like in conflict settings, we know that there is an increase in sexual abuse and violence. This is going to lead to a spread of HIV. And then, as I mentioned before, the trauma, the contact with blood, and if you don't have sufficient PRP or PEP or personal protective equipment, this can be a danger to your healthcare workers and to those public helpers who step in to assist. Next slide, please, Ethan. And so with our tiny babies, those babies who are born premature, those babies who are born through a complex birth and maybe injured, there's a significant increase in premature, complicated births, and of course, mortality. And then this will impact the maternity services. And they might not have access to HIV prevention and treatment medications. The nutritional status could be compromised because the mother does not have enough access to nutrition. This could lead to failure with breastfeeding and failure to access a supplement for the child. And so we can see there's this whole group of issues that impact on that tiny baby. And of course, this means we need more neonatal palliative care in a situation where there isn't enough palliative care or pediatric palliative care. Next slide, please. So what do we do? First of all, we need to integrate. We need to ensure that HIV/AIDS care and treatment is integrated into the country emergency plans, but also into the humanitarian health response plans as well. And we need to collaborate in our response. And so while we don't particularly have palliative care guidelines for humanitarian settings for people with HIV and AIDS, we do have guidelines on palliative care for people living with HIV and AIDS, and we do have guidelines on HIV in humanitarian settings. And so there's no reason why we cannot combine that knowledge in both guidelines and apply that until we have our own set of palliative care guidelines for people with HIV in a humanitarian setting. And we do this often with palliative care. We work together with specialists, with people working in a particular field to integrate palliative care. Next slide, please. And you'll see from this set of guidelines that came out from WHO a few years ago and that some of us contributed to, they talk about integrating integrating palliative care into symptom relief in humanitarian emergencies, integrating into pediatrics, integrating into primary health care. So integration is something that is essential if we need and want and really plan and have the vision for reaching everyone who needs palliative care. Next slide, please. But we do have success stories as well. So when the first invasion of Ukraine happened almost 2.5 years ago, many of the HIV sites were impacted. People, of course, people were moving away from the war zones. There was a mass migration of people internally and externally. But by working together, the Public Health Center of the Ministry of Health, and most importantly, those non-governmental organizations on the ground, a community response, working together and supported externally by WHO, by PEPFAR, by the Global Fund, working together, they were able to set up again these HIV sites in areas that could be accessed and to then reissue the treatment, medication, the testing for people with HIV. And Ukraine in Europe has one of the highest incidences of HIV of any country in Europe. So by working together, by collaboration, by integrating it into existing health service, by the community saying we also are responsible, we have a successful rollout of antiretrovirals in Ukraine, despite the ongoing conflict. Next slide, please. And so within a humanitarian crisis, this is a very good article, journal article led by Alise Nouvet. And some of the findings about palliative care and humanitarian crises are applicable to whatever conditions are seen and to HIV. And they specifically mention HIV in their literature search as well. We know that people are not sure still about defining palliative care, whether it's in a humanitarian crisis or outside of that, that we do lack guidelines. And if we lack guidelines, we lack training, the need for a culturally sensitive approach. When you enter into another country, we've talked about the supply interruptions, but also the other frameworks that are often missing are the ethical and legal frameworks and the support for the moral distress. And of course, what we need everywhere is leadership. So let's look for leadership in this particular field and to remember that it's okay to be imperfect. We can't give the same level of palliative care to people with HIV in a conflict situation, in a humanitarian crisis, as we can in a settled situation. Next slide, please. And so what we need, where the gaps are, we need more research. And of course, from that research, we can develop guidelines and education, and we need the advocacy voice as well. So the good news is, PALCHASE, we have committees for all of that, all of those different areas. And if you'd like to join PALCHASE and join a committee, you can do that through our website. Next slide, please. And so we know the palliative care can be given in humanitarian settings. We know that all the different areas of palliative care are important, but with HIV and AIDS, an outcome is improving adherence and then saving lives. And at the end of the day, it's about giving hope. And the next slide, please, is just a little bit about today. It is Mandela Day here in South Africa. And everyone is asked to give 67 minutes of their time to some form of community service. And a lot of that is aimed at people living with HIV and AIDS. And as Madiba said, give a child love, laughter, and peace, but not AIDS. And how we work together, how we work hard with dedication to achieve another miracle, winning the battle against AIDS. We have the depth of compassion to achieve that, and we can heal. And we do have that same dedication, hard work, and compassion to achieve that in humanitarian settings as well. So happy Mandela Day to everyone. Thank you. And thank you, Ethan.
Great. I hope I'm unmuted and you can see the slides now. So thank you, Joan, for this overview. And I hope with what I can do is to add some hope to what Joan was talking about. I'm grateful to Pal Chase. My name is Rick Bauer. I'm a board certified chaplain. I am at George Washington University. I'm a faculty member of the George Washington University Institute for Spirituality and Health, faculty on the School of Medicine, and I do clinical chaplaincy at George Washington Hospital as well as Children's National Hospital. And this was after 25 years in East and Southern Africa. And so what I want to talk about is integrating palliative care into standardized HIV clinical care and talk about the biopsychosocial spiritual model of care. And those of you that know Joan, she always talks about the children. Those of you that know me know I'm always going to talk about that spiritual domain that often gets neglected. So palliative care is the biopsychosocial spiritual model. This is not new. We started this in the 1960s, looking at a person's health status, maybe some genetic, their diet, their life, their medication, what's going on biologically. We look at the emotional or psychological issues, and we've gotten actually pretty good at this. We look at the social dimension, and Joan did a beautiful job talking about how socially people with HIV are often subject to horrible stigma, discrimination, both from the community and sometimes from within themselves. But we don't talk, I don't think, enough about the spiritual, that which gives our lives meaning, purpose, and connectedness. And I'll talk about this in just a minute. So as I was introduced, I've been kind of doing this since 1982, and I had to get out my calculator, and yes, that means 42 years. And I remember, and I know Joan remembers, that those early years, HIV, the focus was really on hospice. And unfortunately, people were saying an HIV diagnosis was a death sentence. And so they were really struggling years. And there we focused on hospice and palliative care. And we did focus a lot on pastoral and spiritual care, almost not because it was the right thing to do, but because there was nothing else. We didn't have medicine. We didn't have treatment. We didn't understand this virus. Then there was kind of growing focus on spiritual care for staff, volunteers, and the grief work. We did a lot of really focus on, grief and loss for staff, for volunteers, for community health workers, as well as our patients and families. It was 1996, the International AIDS Conference in Vancouver, Canada, and they announced triple drug therapy, what we now have as standardized treatment for HIV infection. But it wasn't until 2004 that highly active antiretroviral therapy, or HAART, was really integrated into the developing world through the Global Fund and through PEPFAR. And then the focus became testing, getting treatment, getting those pills. There was some emotional, there was some social, there was a lot of physical care. And then I remember, and I think Joan might remember, in 2008, PEPFAR had this new, they called it differentiated service delivery. They thought they had invented this. This is palliative care. This is patient-centered care. So the UN then said, our goals are 95, 95, 95. We saw the map Joan put up, but we cannot end HIV unless 95% of all people that are infected with HIV know their status. 95% are then on antiretroviral treatment, and 95% have viral load suppression. But I'm on a plane Friday afternoon to Munich, because I'm going to be the voice that says, unless we have a comprehensive public health intervention that includes assessment and treatment for individuals, physical, emotional, social, and spiritual well-being, we are not going to end AIDS as a public health threat. I was many years in Kenya, and both Kenya and Namibia, there's increasing anecdotal incidents, some research, not enough, about loss to follow-up for treatment and death as a result of people saying, I'm tired of these medicines, I'm just going to pray to God, go to a faith healer, sometimes religious, sometimes traditional, and for 2,000 shillings, the faith healers are going to cure me of my HIV. I remember where I was, that it was a faith-based organization, but my staff wasn't talking about spiritual beliefs, because they said, oh no, Father Rick, we don't do that, because we want everyone to be welcome at our clinic. And there wasn't an understanding about the difference between proselytizing, trying to convert people, and a spiritual assessment. So as Joan said, people said, why do you need palliative care? We have antiretroviral therapy, and I've been a voice in this field to say we have to have this paradigm in HIV care. And we know this improves the quality of life. Facing a life-threatening illness, that's HIV, through the prevention and relief of suffering, by early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. This is whether we're doing palliative care in Washington, D.C., or we're doing palliative care in remote villages in Sudan. So by 2016, we had some real expertise on the medical, the pharmaceutical, the virological aspects of HIV. The International AIDS Conference in 2018 had that incredible study that undetectable equals untransmissible. That if your viral load is undetectable, it is biologically impossible to pass the virus on to another human being. Game-changing in terms of HIV prevention. We've had outstanding mental health professionals on the emotional and psychological aspects of HIV disease and living positively now with HIV. And we've really begun, we're still not there, to name and describe the social aspects, and as I said, particularly the impact of stigma and discrimination. But still, and this gets back to the research, very, very few are looking at the spiritual domain of assessment, care, and treatment. And this is what I believe we must do. You've heard me talk, when I talk spiritual care, this is beyond religion. Spirituality is that deepest part of us that brings us meaning and purpose and connectedness. It's how we experience relationship to ourselves, our families, our community, society, nature, or the significant or sacred that some people call God. Our spirituality is expressed in our beliefs, our values, our traditions, and our practices. So just to give you an example of hope before we get on with some more great discussion, when I really wanted to focus on integrating spiritual care into the palliative care paradigm, into HIV treatment, I started with my senior management to make sure that they understood. We had education and training from senior clinical staff in nursing, social work, and our community volunteers. I utilized our colleagues from KEPCA, the Kenya Hospice and Palliative Care Association, to unite with us and teach our staff about palliative care. And many were initially resistant. Our people aren't dying. Why do we need palliative care? Then they got it. So we integrated spiritual assessment and palliative care into our program. And we had about 30,000 people on treatment at 12 different sites. And at any given time, about 10%, 10 to 15% of our patients are refugees, mostly from neighboring sub-Saharan Africa, as Joan showed in the map. We incorporated a spiritual history tool and some quantitative measures to help the interdisciplinary team understand how a patient's spiritual beliefs and practices may enhance or at times impede treatment adherence. This is not, and I want to be really clear, this is not about staff imposing their beliefs on patients, but to establish this milieu that at our clinic, we value the spiritual aspect of every person. I present but never impose a model of care and treatment that is about prayer and medicine, not prayer or medicine. And we integrated spiritual care into our electronic medical record. We made then the policy that a spiritual distress assessment and history for all new and returning clients within 30 days. This, we know, addressing spiritual issues can have a positive impact on the patients as well as the caregiver's well-being. Understanding how that patient creates meaning and purpose and connectedness is really important on how they deal with illness, health, death, and bereavement. This is more than praying with patients, but a really deep listening of an understanding of what is most important in this patient's life. And I'm getting way down. For our children, Joan, we believe, and we had what we called Operation 000. 0 missed appointments with their clinician, 0 missed doses, 0 viral load, and heroes are zeros. I'm going to skip this slide for right now and go right to the data. So when I got there, our children in 2016 had about 68% had viral load suppression. This year, 91% have viral load suppression. These are children under 9. Our adolescents, another challenging population. When I started, before we integrated spiritual care, 64% of them had viral load suppression. This year, 93% of our adolescents have viral load suppression. That comprehensive bio-psycho-social spiritual model, person-centered palliative care integrated into HIV care. And then our adults. About 83% had viral load suppression in 2016, and this year we hit 97% of our patients have viral load suppression. This is possible if we integrate that palliative care paradigm. And I want to stress that there was no difference from the quote, the Kenyan patients and our refugee patients. The data is the same for each. I'm sure they'll share these slides. There is some really good new research on the Journal of the American Medical Association on spirituality and health and serious illness. Some spirituality and religion with patients with HIV. If you need any of these articles, you can email me at my email address, or if you are interested more about training and how can you and your site integrate person-centered spiritual care into clinical practice, George Washington University offers the interprofessional spiritual care education curriculum. You can get more information at the website. I also invite you to join the Global Network for Spirituality and Health, and every 2 weeks we send out mailings on some new research. And with that, I want to hear from you.
Thank you so much, Rick and Joan. That's great. And welcome to those who've joined. We've just had two great talks. If you missed them or missed a little bit of them, particularly Joan's talk, it will be available on our website, and slides will also be available. And thank you too for sharing where you're joining from. I'm counting that we have, I think, 12 countries represented. If you haven't said where you're joining from, then please do. And for those of you who had some struggles joining, you're especially welcome. This is a webinar focusing on HIV and AIDS in humanitarian settings, and chosen to combine our webinar with the international conference that is being held and that Rick told us he's attending. Oh, I just added another country or two. Isn't that wonderful? So I think we're very well represented from Africa, which is fantastic. And we have Philippines and Indonesia joining us, as well as the UK and South Africa and the US. And that's the person I'm going to introduce in a moment. But before I do, we're going to have a conversation together. We're leaving time for that. So please start to think of what your questions are, your comments are, and start to put them in the chat so that we can really get a good discussion going. So on our panel, we also are joined by Ethan Harned. Now, Ethan's joining us from Kentucky in the middle of the night. Ethan is a medical student at Notre Dame, or Notre Dame as we would call it, and he has recently had an internship in South Africa. He also works with Global Partners in Health. Ethan, welcome, and just tell us a bit about yourself before we get into the full panel discussions. Thank you.
Greetings, everyone. So as Dr. Lang kindly mentioned, my name is Ethan Harned, and I'm a student at the University of Notre Dame. I have also worked for the last 2.5 years with Global Partners in Care and done a bit of work in advocacy and education across sub-Saharan Africa and palliative care. And I've worked really closely with a lot of organizations in Uganda and then most recently in South Africa. So over the last couple of months, I have been in South Africa working with Joan here on exploring how palliative care services can address the social determinants of health in adolescents living with HIV. So to kind of provide a little bit of a high-level overview of what we did, we were really looking at how a lot of these social determinants, such as stigma, poverty, access to education, community violence, the developmental needs of adolescents, and other factors are really having an impact on health outcomes in adolescents living with HIV. And then the other aspect of the research we were looking at was really exploring how palliative care services were really using creative models to meet the needs of these adolescents living with HIV. So thank you, and I look forward to kind of being part of the panel today.
Great, thanks so much, Ethan. Now we're joining from 15 different countries. We have our own experiences, both of HIV/AIDS, palliative care, and humanitarian settings. So let's make this a discussion together. Please put your comments and your thoughts in the chat, and don't worry, they don't have to be sort of just give us what you're thinking and what the questions you have, and together we'll work through that. Rick can't be with us. I'm going to channel Rick a little bit and bring my own experience working in humanitarian settings and as an internal medicine physician working in Africa, India, and the UK and some other countries, particularly including Gaza. So let's get started a bit. I mean, I think I heard from you, Joan, a lot about the need for integration. And I heard some models, and thank you for telling us about Ukraine, where HIV/AIDS has been a problem, and you told us about integration. What do you think the common lessons are that Ukraine can teach us, but also that we need to think about, particularly in these fragile and humanitarian settings? Thanks, Joan.
Thanks so much, Moira, for the question. I think what is really important is collaboration, respect for each other's expertise, willingness to learn from each other, because that is so important. Because unless we all work together, we're never going to achieve the aims. Then, especially with palliative care, we aren't enough palliative care practitioners in the world in settled countries. And if we think that we're going to bring in specialists with palliative care in large numbers into humanitarian settings, it's not going to happen. The way we're going to get it is by integrating palliative care into the different systems, into the approach of humanitarian health responders, and really advocating 10 years after the WHO resolution that every country integrates it into their health system, because the health system of the country is the primary responder, certainly in the beginning, and when the crisis is over, they're the ones left holding the baby. And so unless we integrate and not get too precious about we're the palliative care specialists, and recognize and respect, and especially respect people in the community. You know, what NGOs can achieve is often far more impactful than what a great big organization achieves. And as I said, those are the ones left holding the baby at the end. So let's get our communities on board as well.
Thanks so much, Joan. I mean, my recent experience, and I think what you're describing is improving the health system, and the health and social system being more than just a healthcare professional. And if we do that, then that's the best chance of actually making a difference for HIV/AIDS, but also I think for all of our chronic illnesses. Just to bring in a bit of experience that I've had recently, working with colleagues in Gaza, I see Dr. Nahla Ghaffar and others on the call, is that there is a framework for how we respond in emergencies or chronic illness. And that involves working to prepare in fragile settings that are vulnerable to emergencies or humanitarian events, and then responding during the emergency, and then responding in the, we hope, rebuilding phase afterwards. And what I was seeing in Gaza was that the preparatory time is so important. If you haven't integrated before the emergency, it's difficult to do during the emergency. The rebuilding, I think more of us, or many of us, have been involved with in different places. I know Northern Uganda, we may share some unique models from there as well. But what I did also see, and this was very disappointing, was in the emergency phase, chronic illness gets pushed to the side by the trauma and surgical response. Now, I'm not in any way knocking the trauma and surgical response, absolutely essential, but it needs to be integrated with an NCD response. And WHO EMRO, that's the Eastern Mediterranean region, have produced a framework, and there has been now a high-level meeting with WHO, which was very, very positive in February, bringing countries together to say that this needs to be integrated. So I hope we will see more going forward, but I still think we have a big gap in Gaza after 10 months of a terrible, terrible war, which is now being formally declared as a genocide. There is almost no support for those with chronic illnesses, which would include HIV/AIDS, although that's not a major problem there, and all other chronic illnesses. I don't know whether you have any other thoughts on that disconnect between what we need and what's happening in the emergency response, Joan.
I think what we've seen in Ukraine opposed to Gaza is because they had an established palliative care system funded by government, they still receive government funding despite everything, is that those palliative care organizations that were not in the acute war zones were able to continue providing palliative care. at a community level as well, and at a specialist level. And so I think the difference between where you have palliative care integrated into the health care system and into the community healthcare system, and where it hasn't been integrated, is quite stark. So I think our greatest advocacy should be for every country to get it integrated into their system so that it is there when a crisis happens.
Thank you so much, Joan. And I think Gaza's Trouble, we had quite a lot of integration, but unfortunately, there were no areas free of conflict. And I think that's the other crucial thing. But still, our organisations, including MSF, were saying they couldn't respond as they would like to because the policies were squeezing out chronic illness. So I think we have some work to do, and I'm glad to see comments from South Sudan showing where MSF has done a brilliant job and is continuing to do so, working closely, of course, with local colleagues. I'd like to bring in Ethan now. Ethan, you've highlighted such a crucial part of our community, and that is the adolescents going through their own transitions, and then you add in a chronic illness, and then you add in a humanitarian setting. Just tell us a bit more about what you've learned and how the adolescent community can both receive the help they need, but maybe even contribute to how that help is given.
Thank you. So I think, one of the biggest things that we looked at from the South African context, but I think that has some global relevancy as well, especially in a humanitarian crisis, is that adolescents are often forgotten about in the provision of services. And we typically have pediatric services and we have adult services, and they kind of get lost in the middle ground. And especially when looking at HIV services, where follow-up is so crucial to the long-term success of a patient, it's important that there are kind of some tailored services, because adolescents have very unique developmental needs, which oftentimes can put them at a greater risk due to kind of some of their increased desire to engage in risky behavior and really expand their social network, which oftentimes in a more unstable community setting can result in gang violence and sexual violence. So I think there's a lot of unique challenges within adolescents that make them quite vulnerable, especially in a health context that doesn't take them into consideration. And so I think in order to really accommodate them, one of the best things that we can really do is listen to them and discover what are some of the needed systems in place to really support them. And so, one thing that's come up a lot, and I think there's so much literature backing it up, is peer support, but really understanding how to facilitate peer support in a setting where social circumstances limit the availability of that service is so vital. And so, thinking of creative ways to meet the needs of these adolescents and really still make sure that you are being present and having a compassionate and forgiving voice to them through some of those developmental challenges is really quite crucial to ensuring that continuum of care with this age group.
Thank you, Ethan, and thank you for that reminder. And I think it's, we sometimes see people as needing our help, but actually, I think this message, which is very clear, that we should be listening, and that it is actually together, it's a partnership, isn't it, between the help that we're able to offer and the experience and the cultural relevance and the knowledge and the capacity of those that we have the privilege of partnering with, and that includes in the humanitarian setting. Nahala has reminded us of the importance of biopsychosocial and spiritual model also in cancer care. And I think Rick took us on a journey from predominantly spiritual interventions because there was no other treatments, to the danger of, as soon as you get a treatment, moving straight to the biological model only, and the importance of actually maintaining that. Again, if we look at in Gaza and mass casualty events, what we're seeing is little help and little support for those with chronic illness, even in the middle of mass casualty events. And we're also sadly seeing this mirrored in many other settings. So how do we keep the spiritual aspect of care front and center, and what does that mean in different settings? Now, Joan, I know you have a particular interest in this as well. So do you want to just comment more about how we integrate the spiritual aspect of care into these fragile settings?
Moira, I think one of the problems we have is people confuse spirituality and religion. Is that spirituality, as Father Rick said in that definition, is about connections. It's about meaning and purpose. And you can be very spiritual without being religious. And I think so often we confuse the two. And so I think, as you have spoken about, and as Father Rick spoke about, is how we communicate, how we listen, how we connect. And those qualities you can take into a complex situation, into a humanitarian crisis. When you're dealing with patients, with people who are terribly distressed, we can take those spiritual qualities of listening, respecting, connecting on a human level, using connections to nature where we can, and respecting religious beliefs, which are often a method, a mode that we use to express our spirituality. As Anne Merriman says, spirituality is the journey, and religion can be the mode of transport.
Thank you. Thank you. And that sense of deep listening it came through in our webinar yesterday. It's coming through in our discussions today. And sometimes it's not necessarily about what we can do, but what we can, what relationship we can build. And from then there may come the creativity. I'm delighted to hear from Halima. Halima, I know very well. She's a very senior nurse and was leading a program in a cancer center in Medini in Sudan. And now, of course, that has been completely destroyed in terms of their access to that hospital. They've had to flee. And Halima is telling us that she's in Port Sudan and asks a very important question. We set up, we integrate, we work all we can, and then war comes or another humanitarian catastrophe, and the situation completely changes. And I suppose, Halima, you may know more about this than many of us, but let me just give some thoughts and some suggestions from the experience of elsewhere. And I know that also Sudanese colleagues, Nahala, may want to comment in the chat too about the work that she's been leading. And I think we come in these acute events back to the basis of what we do in palliative care. So it's, what can we do holistically? What can we do with the resources that we have, which may be very, very different from the resources that we would like or the resources that we used to have? How do we care for the carers? Now that means the informal carers plus the healthcare workers. And what struck me working with colleagues particularly in Gaza recently is how devastating it is for those who are the healthcare workers, who also have experienced displacement, grief, loss, and are then still, and the courage of this, trying to care for others in that circumstance. And addressing the grief and loss. Now, addressing the grief and loss may not mean counselling and support in that moment, because it could be in the middle of a traumatic event, that what we need to do is recognise and support. And psychological first aid principles helps us to do that. So we listen and listen and listen, and then offer support and referral if we have it. But there may be times also where people would appreciate an opportunity for more targeted support for trauma and for grief and loss. So I think that would be my sort of tips for getting started, Halima. But if you want to write a bit more of your experience there, or what you've learned, we would be delighted to see that in the chat. Please do that. And I'm really wishing you and everybody in Sudan well as you contend with an ongoing and very severe humanitarian crisis there. But we do have a question here about stigma in adolescence. So maybe I'll move a little bit while we see. Oh, Nala, let's just comment on Nala first of all. Yes, so she's talking about identifying those people on the ground, giving them hope. I think that's great. Thank you, Nahala, for reminding us of the need for hope. And hope can be in the small things of life. as well as in the bigger things, and just simply waking up to face another day or to celebrate that you have lived another day, and then prioritizing what patients' needs are. I know that Nahala has been working hard with colleagues in other parts of Sudan to see how we can offer psychological support for patients as well as staff, and get medicines in if at all possible. Back to medicines, if you don't have medicines available before the crisis, it's going to be almost impossible afterwards, but it may need very, very flexible joint working, and WHO have been supporting this in many places to get medicines in. Mobile clinics, training, tack shifting, retraining, and I know, Nahala, you've been doing some of that, using Zoom and internet connections, and some of the funding that's come in is to support those connections so that folk who are on the ground can do what they can do, but are supported in doing that, even with salaries. In Gaza, for example, after 10 months, no salaries at all. So thank you. These are really helpful points. May I bring Ethan in? Ethan, there's a question here about stigma in adolescence and how we address that. I think that's really important. Would you like to comment on that?
Absolutely. So I think really one of the first things is really understanding why the stigma is originating from. In the context of South Africa with the adolescents that we were looking at, really there were three major areas that we identified. And those were within the clinics, within the community, and then within the family itself. And a lot of that really had to do with disclosure and then lack of visibility for HIV positive young adults and adults in general. And so I think really two of the biggest things that we kind of came across were this need to really increase training and educational resources on HIV for young adults, children, and adults alike, and really give a lot of visibility to these HIV positive advocates to really make sure that they can share about their stories, sure that HIV is, while it's a life-limiting condition, does not have to be a terminal condition, and really give some visibility about how to live positively with HIV. So I think those were some of the biggest things that we really came across, but I think a lot of it is very context dependent as well. And so I want to kind of provide that element as well, that in a humanitarian crisis, there might be intricacies within that that really define where that stigma is coming from.
Thank you, Ethan. Thank you. I think stigma is very alive and well in many places, and addressing it before the crisis is the crucial thing, isn't it? Understanding how to develop those relationships. Joan, we have a heartfelt cry from the Philippines, where the question here really is about integration is a word that's used, but in reality, not much voice is given for palliative care. Would you like, I know as the advocacy lead here in Palchase with Rick, would you like to comment on that?
I think this is a many-year-long problem that we've had as a palliative care community, Maura, you know well, is that how do we get that message out there? And how is it that palliative care is always put like at the end? You know, if there's a budget, it's prevention, promotion, care, rehabilitation, and then if there's a little bit left over, something for palliative care. And I think one of the problems that we do have is that it's still so linked to hospice, and hospice is seen as end-of-life care. And we know that palliative care can be given over many, many years. And also people can actually go out of palliative care programs as their disease improves.
Right.
So I think we need to relook, and we need to be looking at new ways of presenting what palliative care is. So to be honest, I don't have the answers. We've advocated for so long. We got a WHO resolution 10 years ago.
I think Joan's voice is coming and going, but I think, I think I hear the message.
Country who was a member of WHO signed it. Yeah, sorry. I think that we do need to look at new ways of presenting what we do with palliative care. It is a challenge, and I know the Worldwide Hospice Palliative Care Alliance, their theme this year is 10 years from the resolution. Where are we now? And so, especially for our younger members here today, I really would like to say, just give us your ideas. How do we make palliative care So it's totally accepted as an integral part of every health system.
Thank you, Joan, and thank you
I
for
don't
your
have
work
the
in
answers.
advocacy. Yeah, no, great. I mean, this is a team effort, and Philippines, we're with you. We'll try and do our best to support you in any way we can. But look where we've come from, and look what's happening. Piece of work we were doing was, and even that piece of work we were doing with the WHO, people knew about palliative care in general.
Yes.
Not everything about it. Still some myths. We have got it on the map. Well done, everyone. Now let's work and keep working to find models of integration that work in practice. And I know in Northern Uganda, the models there have worked very closely with the community, using village health teams, community health workers, people who are used to addressing stigma. And they've talked about the stigma of HIV/AIDS and other chronic illnesses, and being members of the community, having training, having recognition. And then we also developed a mentorship model and research models that use the voices from the community to tell their story. And it was the community itself that turned around the stigma with support. And then they were identifying those in need of palliative care. And we were strengthening the referral pathway, led by our colleagues on the ground, to allow those patients then and families to get the care they need, and to allow the voices to be heard by the healthcare system. So different ways we can do this, but let's keep going. We're just a few minutes to go now. And Erin, I think you had a comment you were going to just add about adolescent care.
I was just going to echo after Ethan had shared just about how stigma can be complex with adolescents. It is also a big time in an individual's life. So I know that for many adolescents, accessing healthcare can be a challenge regardless, but then having also issues with a serious illness such as HIV can be really challenging too. So I do think in your settings, if you do have a healthcare worker that seems to get along well with the adolescent patients, obviously not to isolate them just to one provider, but really understanding their needs can be really helpful if they do seem to trust one of the nurses or one of the physicians well, really building into that, because I think it is a time of transition for many children going into adulthood, and the people they trust sometimes is less, just in general.
Thank you so much, Erin. And I'll just mention one other area. I was in Gaza a few months back. I should be there now, but humanitarian aid has been severely restricted, including medical teams, and we weren't able to travel. But when I was in the neonatal hospital, I both heard stories which would break your heart of what had happened to children, but also saw very, very premature babies sharing incubators with septic newborns, premature babies all together, and saw the most incredible dedication from staff, but also the importance of neonatal care. And I, in fact, was with 2 medical students that we'd previously trained in palliative care, and a young family who had their 2nd child born with what was presumably a genetic disorder, not expected to live. And there was just a beautiful moment of palliative care for that family, with me as the external person, but with the medical students translating and supporting on the ground, which was just wonderful to see. So don't forget about the neonates, as well as was mentioned before. I'm just going to ask our 2 speakers just to give us just a word of hope, or a word of, just encouragement to move forward on this issue. Ethan, can I come to you? Give us a word of hope or encouragement that you would like to share.
Of course. Well, speaking from especially my experience in my most recent work, I think my hope is that we can really give a voice to these vulnerable groups, such as adolescents and children, and really those in humanitarian crisis leading with HIV. I think, a lot of these vulnerable groups are such pillars of strength and have overcome so much in their pursuit of survival. And I think, giving them this voice, allowing them to express what they need, is really my hope for the future, so that we can better address the models of care and what is needed in these populations, and then also really give them the strength and the empowerment to be the leaders on a lot of these major pressing issues. So I think that is my hope for the future.
Thank you. Wonderful. Over to you, Joan.
I think my hope is that palliative care, which has on the one side has immense knowledge and skill, and on the other, the beauty of compassion and care, is increasingly recognized as not only an essential part of healthcare, but also of the work of every single one of us as we care for our communities as well. And we are moving forward. I know we'd like to move forward much faster, and it sometimes seems as though we get stuck in a quagmire, but palliative care is moving forward. And I think in humanitarian settings, it is more needed than anywhere else in the world.
Thank you so much, Joan. Can I just encourage you to click on the joining link if you're not part of the family of PALCHASE. Our next webinar will be 23rd and 24th. And I would like to finish by saying a huge thank you to those of you who at the moment are doing this. You're working and joining us from places such as South Sudan and Syria, and we think of colleagues in Ukraine and Gaza and Yemen and Myanmar and so many other places. Thank you for all that you're doing to put these principles into practice right now. And, you know, we stand with you in solidarity, and we also stand with, as all of you, as we seek to bring hope into situations which are very, very difficult, and to bring humanity and solidarity and to change what is happening, building on the work that has been done by many others. So thank you to all of you for joining. Thank you for the comments and the questions that have come. We'd love you to be part of our PALCHASE family. So please do click and link and join. And as Joan said, we really want your ideas and we want your input. And Nala, that's just a lovely comment you've made too about those who are working in these situations. There is hope. Nala chose to call the program she's running in Sudan Sunshine in War. So there is hope because of the solidarity and the humanity and the relationship. There is hope because of the many things that give us spiritual strength from our faith, from all our connections, from everything else. And so we finish on that note of hope. Thank you so much to everyone.